All. This is Dr. Mobeen Sayed from Drbeen.com. Welcome to one more show. So please remember, tomorrow we'll have Professor Dr. Eli Schwartz from Israel talking about his ivermectin study at 11 a.m. instead of this time. And now let's continue our discussion. I hope it is useful, and I am very excited not only that the long haul protocol is published, but also for the understanding for what may be going on. There is a possibility of mast cell issue, or a macrophage issue, or a viral hit and run, or just the debris sitting out there and causing issues. And we have to there are some drugs that are common in many of these, and there are some drugs that are separate. So it is going to be a protocol, as you see, where doctors and patients will have to work together to figure out what is the right approach. So, Carrie, how are you? And Carolyn, I saw you on the FLCCC as well. I was so proud that everybody had a bean name. It was funny that Dr. Yo had Yo Bean, but then he texted me and said, "I want to be Mean Bean." And by that time it was too late, and he was announced as Yo Bean. But so Dr. Merrick is soybean, Dr. Pierre Corey is coffee bean. Remember, he said, "I want to be a Papa Bean," and then he wanted to be a coffee bean. And we have a cool bean on Twitter, Avox, who used to be the coffee bean, and Avox very generously and kindly gave up coffee bean to Dr. Pierre Corey, and Avox took mocha bean. So we had those beans. Then Dr. Tina Pierce has taken Beanu, and I was humble bean. And then we had Dr. Yo, who was Yo Bean. And then, Carolyn, I saw you there as well. And most of the people there who were from the Bean family, they had their bean names. They were talking about that, I am this bean. So I was very happy. So Algebra Bean, how are you? Shri, how are you? Diaz, how are you? Loretta, how are you? Excellent talk today, Dr. Bean. Very helpful. You're very welcome. Thank you. Carolyn says 3-way tie. Where is France? Emily Wiggins. Hi, Bean. Thank you, Doug, for this info tonight. You're very welcome. Is Doug here? Because Kidney Bean, yes, hello. Skyfrog is here, hello. Where is Doug? I want to say thanks to Doug for his... Doug asked this question yesterday, and then Doug did some Googling maybe, and then came back in the same talk yesterday and said, well, they all have the locked protein. And then I had to go and see it. Here, Doug. Hello, Doug. How are you? Arun, thank you very much. So it turned out that let me share my screen very quickly. It turns out that locking of the spike protein in the pre-fusion state is an old idea, and for that locking, the mechanism was discovered by some researchers, and that mechanism, they published that in a paper, I think 2015 or so, and that mechanism has since been used for vaccines for coronaviruses, and not only for coronaviruses, even for other respiratory viruses that may have spikes of the same type. So that was that there is a part of the spike protein where two prolines are substituted. Two prolines are substituted with their other, other amino acids. So this is called 2-proline mutation spike protein. And that is the one that is locked. So Doug, thank you very much for kind of digging in first, and then I went on your footsteps and looked into it. Okay, so oh wow, that was from memory. If it matters, very good. So even more better. Doug, you're awesome. You should be given an award. Anonymous says, how do you treat people with ivermectin if they are asymptomatic or mild COVID? What treatment do you recommend for pregnant? So ivermectin, asymptomatic, generally by definition, it will mean that you don't even know. So when we don't even know other than prophylaxis, there is no time to know they are there and treat them. But if you find out that somebody who's asymptomatic is positive, same treatment, COVID, ivermectin, how do you find they are positive? For example, you are testing. Now, mild, same thing, and there is a protocol. You can see it on FLCCC. I've discussed many of these things as well. Pregnant women is a Dr. Samina Chaudhary had been asking for this for a very long time, and I am not able to offer help until I do good research. I am very scared of children and pregnant women's state and try to manage them because I've not, and then I don't want to say something. So that is one area where I'll have to do research and then discuss. Without that, I don't want to open my mouth. Colin Hamill says, can hay fever be mistaken for the virus? I suffer bad with it for over 50 years and it's killing me now. Watery eyes, no breath. It can be, but get your test done. Because if you have suffered it for 50 years, you know exactly what kind of symptoms you see. If these symptoms that you're seeing are different, then I would suggest that please talk with your doctor, get your x-rays done, and then you've been with us for a long time. You know what are the things that must be looked at. So get well soon, and please take these things that we've talked about. Reach out to me if you want to and discuss it. I am from the Caribbean island of Trinidad. Very good. And yesterday, Avox did something. Avox wrote a modified song for me, which was by human beings in 1968. So that was so cool. Texas says, I was first for the lecture and to power, but I'm so humble. I don't brag. Thank you. Algebra Bean says, was at the FLCC webinar. Excellent presentation. Thank you very much. Heather says, Dr. Bean, why would we have inflammation when CRP, ES, and other markers are normal? My doc thinks I'm lying. No, so there can be low base level inflammation. Look, it's very simple. If a person is exhibiting signs and symptoms, they have something going on. Very simple. And it's very rare for healthy, normal individuals to go and start lying about this situation. I see people who have well-built, exercising, athletic, young people running around, doing things, all of a sudden saying, I can't walk 10 feet without becoming breathless or without having tachycardia. So all of a sudden, a massive number of youngsters, healthy, well-built, beautiful, decided to say, we have a problem. So it is a problem, actually. So David said, how could endothelium be affected by the long haul? So I explained that in my last talk. I don't think that endothelium is directly affected by the spike proteins. Endothelium can be affected if the fight inflammation is going on in the tissue just under the endothelium, and that can affect endothelium as well, but not directly. Or let me say it this way. So far, the pathologies that are surfacing, they don't have endothelial damage, but it may be. There is one interesting thing, and that is the presence of VEGF, or vascular endothelial growth factor. What happens is a tissue where there is damage, for the repair, our tissue want to make more blood vessels there so that it can bring more blood there, and it releases VEGFs. VEGF, it in turn tries to work on endothelium, and there could be further issues with endothelium. Emily Wigan says, hi Beans, and thank you, Dr. Bean, for this info tonight. You're very welcome. So Roman says Jana's surgery is today, right? Prayers for her and that everything goes well. Yes, and I hope she is doing well. James says, did you see, James Newen, did you see that a superstar gene that makes people more sensitive to bitter flavors may also help protect against COVID? No, I did not. Very interesting. Can you tweet that to me? Histamine warrior bean. Hey, Denise. Michelle says, ready for chit chat. Mean, James Newen says, mean bean. Okay. Thank you, Roman. Catherine says, thank you so much, Dr. Me. This has been so interesting for more than COVID long haul. Absolutely. Thank you very much for being here. Jody says, okay, great. I made it late, but didn't totally miss. Hi, Dr. Bean and Cool Beans. Hello back to you as well. Okay, so more questions. I like this. So, Red Poor Jack says, that must mean I'm part of the Cool Beans now. My Cool Bean name shall be Beanstack, like Jack and Beanstack. Absolutely. You are not just part, you are the Cool Bean. If you're here, you're a Cool Bean. Lizzie says, what is a good test to check for antibodies? So there are many antibody tests. So whatever, if you go, just, there are two kinds of tests. One that just says positive and negative, and then the other one that looks at the titer and tells you the titer, and then it tells you what levels. I would prefer a titers test. So Jean says, good question. Acknowledging that the spike protein is locked, just like I have on the diagram here, in the pre-fusion state in the vaccines, could you clarify what pathway could conceivably be causing post-vaccine symptoms? Yes. So couple of pathways. So put this protein here. Let's say it is in the nanoparticle, not nanoparticle. It's messenger RNA is in the nanoparticle. So let's say messenger RNA is in the particle. From here, it goes into some cells, which could be immune cells as well. It could be muscle cell, it could be immune cell, fibroblast, the cells in the area of deltoid, and these all are there. Now, when the messenger RNA is in there, it's going to create this spike protein. And boom, we have a spike protein inside a cell. And imagine if it's a macrophage. And imagine this spike protein, as much as it is locked and cannot go and do binding with the ACE2 and cannot do any of that destruction, if it stays in here. Now, the question that should be asked is, why does it stay in here? And my answer will be a question as well. Why does it stay in monocytes? So what is causing some spike proteins in some people to just hang in there and not get crushed and broken and thrown out? So there is still an underlying mechanism that we do not know. Why does a monocyte have this protein in it? So the same mechanism here as well. So this macrophage is now dysregulated. Ideally, we know that in majority of the people infected or vaccinated, this would be the protein, we know what happens to it next. But in some people infected or vaccinated, this protein just sits there, bothers them, keeps them in M1 state. I actually think that there is one more mechanism, and that is called frustrated phagocytosis. Although this mechanism is not presented by anyone, but let me show you this. This is not a new thing that I just made up. So if you say frustrated phagocytosis occurs when phagocytic cells are exposed to an opsonized surface and spread as if trying to engulf it, allowing for the... So eventually what it means is, let's say there is a cell, a regular cell, and that regular cell is presenting part of the spike protein on it. Or let's even go this extreme, that spike protein is actually sitting outside. It came out from a broken cell. And now the macrophages are trying to eat it. And for some reason, they're not able to eat it. If they're not able to, they're going to just start releasing cytokines and start saying, we have a trouble. They would even start fusing with each other to make giant cells. And they would try to make a boundary around this thing, which is called granuloma, to kind of trap it inside. But in this process, all of them are going to be totally upset and releasing various cytokines. I think this is a possible mechanism as well. So not just this spike protein hanging in the immune system cell, but maybe outside and not getting enough opsonized to be able to get eaten. Opsonized means that you take some antigen. So let's say in this case, we take a spike protein. So here is a spike protein. And you put lots of complement pieces on it. You bind antibodies on it. You make it sweet for the phagosomes to eat it. So phagosome they cannot work with a slippery surface. They need some sort of roughness on the surface with which they'll pick up the pathogen and eat it, or antigen to eat it. So that could be complement, or that could be antibodies. These things are called opsonizers. And this process of coating an antigen to make it easier to eat up by the phagosomes is called opsonization. So when opsonization isn't correct, and this pathogen antigen is sitting outside, not correctly opsonized, that means the cells are not going to be able to eat it correctly, and they're going to become really upset. And that would also cause cytokines and activation. So maybe it is this mechanism. Question, angiogenesis. So angiogenesis means production of the new blood vessels. So when there is a damage to the tissue anywhere, usually if that damage continues and the cells are activated and the things are bad and dysregulated, then there are VEGF-like things released, vascular endothelial growth factor, which would then allow the blood vessels, existing blood vessels, to have tiny buds from them. Those buds will then start becoming blood vessels for this area. So that can cause vascular dysregulation. These two topics today, the topic before and now, the discussion now, I think these are tremendously important talks. Not because I'm delivering those talks, just the mechanisms to put them together. Yes, I know. I reached out to her to say, hey, do you want to come on Dr. Bean's channel and talk? So Dr. Bean's channel is looking to get blocked as well. Catherine Daly, thank you very much for the super chat. Zunar says, cytotoxic spike protein concern. How would Novavax's virus-like particle tech compare to spikes created by your own cells with current vaccines? So, very good question. It needs a lot more discussion to have, but let's do that. I'm going to try to be brief with it. So Novavax, we talked about this kind of yesterday too. So let's say this is the Novavax spike protein thing, their particle. So their particle itself is nothing but number of spike proteins that are kind of folded correctly, and then they're attached like an edible arrangement. They're attached together like a particle. So this is what they are. And the lipid nanoparticles have messenger RNA that would go into a cell and make spike proteins. Now, if I look at your question, cytotoxic spike protein concern. The question to the answer, we discussed that yesterday too, and that is what I was talking about, Doug's role, and even more fascinating is that Doug said he was speaking off the top of his head. So here, the Novavax spike protein is pre-fusion stabilized. That means there are two prolines that are substituted in the spike protein to lock the spike protein in pre-fused state. And that their basic idea is not to say that, hey, we have to protect the spike protein from becoming fusible and that would cause an issue. They had a different problem that they were trying to solve. They were trying to solve that how do we keep spike protein in the body from a vaccine in a state where it would be naturally occurring when the virus arrives, and our immune system should be able to regulate or recognize it in this state. They were worried that if the spike protein that they built went in and opened up, then this open state or post-fused state for the actual virus will be very difficult to detect, because post-fused state means that virus has fused with the membrane. Now, if you run the antibodies to say, go attack it, they're not even going to be able to see that the virus proteins are fused. So the best way to have the vaccine generate spike protein to be recognizable on the virus were in the pre-fused state. So that's what they were doing. They were not saying we're going to protect the people, that the vaccine should not bind to the ACE2 or ACE or GLP-4. This is what they did. Now, it turns out that messenger RNA vaccines also have the RNA built in the same way, that two proline substitution or mutation is done on them, which means these spikes cannot open, which means they cannot be cytotoxic. Other than, so let's say, how can this be cytotoxic? This can be cytotoxic that when this vaccine is given and the immune system responds, then there would be some damage to the cells. That is natural. Actual infection or the vaccine, that fight is going to occur, damage is going to occur to some tissues. It's just that with vaccine, it's really tiny. Okay, let's see. Where is that account? Here? I cannot imagine that there are folks who are still stuck in the time to say there is no COVID. Okay, blocked. Magdalena says, what do you say about Dr. Fauci getting fired? His emails tells a different story versus what he told the public. That world, the bureaucracy world and politics world, is full of influences, interests, commercial, political. I don't suspect anything useful to happen in that area. You would expect this kind of a thing to happen if people around him and others were more sincere to their jobs and the integrity of the job and the integrity of the outcome compared. And again, this is not directed at Fauci. This is anyone in those places. The CDC is not one person, or FDA or NIH. They're not one people. There are many, many people there. And there are many who are not doing the right thing. So I don't have hope from these organizations, because I think they have too many interests that are influencing them. Okay. Kurt Dish says, hi, Dr. Bean. I have loss of smell and taste, and my partner is just mild. Is 3 days ivermectin enough for us, or 5 days? Do you recommend prophylaxis protocol for mild asymptomatic? So I am actually very aggressive with these acute infections. I give ivermectin continuously till the patient comes back and says, I am well, I'm fine, leave me alone now. So till that time, they get ivermectin. So you can look at FLCCC's protocol and decide to take that. And if somebody has a anosmia, they should take slightly higher dose compared to not. And again, not an advice for you. This is generally what I do for my patients. Denise says, mom suddenly developed what doctor thought was macular degeneration in January. However, she got 2 shots of VEGF monoclonal into her eyes, and now they are 100%. Doctor was amazed. Could have been long hauler, possible, yes. And you're correct that if there is VEGF going on and local production of small vessel buds and those things getting created, that would start hindering with the vision if it is in the way of the retinal, cells, or under those cells, and kind of is becoming opaque. So giving these antibodies and the VEGF is removed and the vessel growth is removed, then she would feel better. Now, could that be long hauler? Possible. But would that just be for the eyes? That is going to be difficult. So did she have anosmia? Did she have anything else? If not, it may not be long hauling. So, good question. So, Jeet says, my brother had asymptomatic COVID July 2020, and he has had 2 doses of AstraZeneca in March 2021. But now his antibodies are negative. How is this? Does he need booster? March, April, May, June. So we know that antibodies would go back down after some months because the body says, I don't have any further exposure to this thing. And body does not continue to make antibodies forever at a high level. If that happens, imagine if from our childhood till whatever age we are, we continue to make antibodies for every infection we encounter on the way. We would be big, huge antibody sacks. So that doesn't happen because our body knows if I'm not finding the antigen anymore, I'm just going to kill those cells that are making it, and I'm going to reduce the actively large amount of antibodies produced. I talked about this a few days ago. There will be bone marrow plasma cells created that would go and live in the bone marrow and can live on for decades. And when the exposure occurs again, they would handle it. Joy Fisher says, okay, so this is a separate discussion. Let's see. Questions. Yeah, so this could be, so macular degeneration and then the VEGF, they are kind of, it could be because of VEGF, but in this symptom that Denise talked about, it didn't seem like macular degeneration, but could be without knowing more. Red Poor Jack says, Dr. Bean, is it at all possible that this virus is another misidentified exosome that is part of how our body spread information between our cells? A messenger RNA, one could refer to it. So exosomes are not the way our bodies do communication with each other. They mostly do communication through cytokines, that is one way, or hormones, that is another way, or neurological signals, that is another way. But I do not know what you may be saying, messengers. Bodies, cells usually do not send messenger RNA from one cell to another. They can be accidentally picked up pieces of messenger RNA by bacteria and brought it to another cell, or viruses that can bring it from one bacteria to another bacteria, and then the bacteria goes into our cells. But generally, we don't have messenger RNA exchanging mechanism. Leslie says, is coronavirus spike protein only part of SARS-CoV-2 or common cold? If so, why doesn't our body already attack spike protein? So it is, coronavirus is about 86% similar to other cousin coronaviruses in our bodies. And it is a good question that if our body knows to work with those coronaviruses, then why does it not attack this one? The important thing to keep in mind is 86% of us have coronaviruses, and we are not bothered by them. We don't kill them, number one. Number two, they change as well. So that is why they can cause infection every year. We are fortunate SARS-CoV-2 is not changing that fast that it would do it every year. So somehow, because our bodies are allergic to the human coronaviruses, meaning we don't bother with them, that is why our human coronavirus presence does not prime us to attack the SARS-CoV-2. At the same time, we still do not know why asymptomatics are asymptomatic. Maybe asymptomatics are asymptomatic because their human coronavirus systems have, or viruses presence has caused their immune system to be enough reactive that when the actual SARS-CoV-2 comes in, they try to handle it, and they handle it with more success. So Sedu707 says, I had a yellow fever shot in the 80s and read it could help with immunity to COVID. I do not know. I have to read that study to understand it. So Jerry says, Dr. Malone, you're correct per design, but developers saw bioactive risk, so engineered anchor, which is fine, meaning you don't want to create a protein that would run away. So creating anchor is good. FDA ruled insufficient documentation, inadequate anchor testing resulted in surprise spikes being cleaved off. Actually, there is a very interesting and simple thing to look at. Instead of getting scared, the simplest thing to look at is the following. Here is a number of people who have gotten the vaccine. Let's use Israel as an example. Almost a majority in there has Pfizer vaccine, right? Pfizer BioNTech. If the spike proteins were running around and then they were lethal as well, or they were going to cause castration by destroying ovaries or destroying livers or causing endothelium and causing people to die, then wouldn't we start seeing that? And this is an incorrect way of articulating to say, well, 2 years later. How come we would spend 2 years with this mechanism? Because there's no time bomb in there to say 2 years later, please start doing this. If this is going to happen, it's going to happen now. And if it is going to happen now, and if it is, let's say, spike protein cleaved off and then doing all the damage that we think it is, then where is that damage that we are seeing? We are actually not seeing that damage even with the active infection to the proportions that are being said. So a spike protein that is locked, even if it is run away, and spike protein is going to spill out from the cells getting damaged and destroyed by immune system. So it is not that spike protein will not come out, but we also know that when it would come out of the cell, in the vicinity of the cell are immune systems, the macrophages and the neutrophils and the dendritic cells and other cells that would pick it up and clean it out. So for us to say things like, here is a bioactive form, we have to then follow it up with the remaining part of the destruction. What will that bioactive form do? So first, just saying that bioactive form has to occur means there are a couple of things. Number one, that anchor has to fail. And the study that we discussed with the anchor failure, these folks are calling it version 1 of the preprint. That's one. Number two, let's say the Japanese study. So I showed some translation yesterday, which was done by a Japanese person, a good educated person. And somebody responded and said, well, that translation is wrong. So I can't work with this, that if I take other translation and say, this doesn't say it, then, well, I am wrong. And now if I get the translation done by someone who I think are going to do a good job, then they are wrong. So eventually, if the basic idea is that, hey, just let us say that it is going to destroy the tissues and ovaries, and fine, then I can't provide an answer to that. But if we want to say that there is bioactivity, the first thing we have to agree on is that the spike protein will get out. And for that, the anchor would fail. And we would see the spike protein outside. One. And now we would actually see spike protein outside in the normal way as well, because the spike protein is going to come out to the cells that are going to be broken down. But let us say that the Japanese study or other studies that say we see spike proteins, they are seeing spike proteins. Then the second thing that we have to agree on is that this spike protein that came out will not be picked up by the immune system at all. And this spike protein is going to go through the whole lymphatic system. It's going to go to a lymph node. This is like some really bad person going through army's barracks. And then after one barrack and the other barrack and all out in the open with a flashlight, with the thing written on his head that I am some sort of a bad person, and still going through the whole thing, and then come out in the blood. Then go and attach somewhere. And even if it goes and attaches to some ACE2, which you know that this was one provision that it would come out. The second provision is that it would escape all the immune system's mechanisms. Third provision is that now it has to bind with the ACE2 as well. And if it is in a lock state, we have to offer another provision to say no more locking. Then the fifth is that the devastation it has to create is enough to destroy an ovary or to destroy a liver or to destroy a heart or destroy something. This is, we're talking about vaccine generated tiny amount of spike protein. If this is all is going to be provided, to me, that simply means what? That simply means somebody is saying to me, man, I don't care what mechanisms, just suspend them all and let the spike protein be hurtful and harmful. I just want that. And then I can go and say spike proteins are bad. Well, if that is the case, then one can just simply say it without those mechanisms. Eileen says, Dr. Bean, would you please ask your guest tomorrow regarding access and cost in Israel to ivermectin? Folks seem to have difficulty getting access here. He may have tips. So, okay, let me actually write it down. So here, so question is about the access and cost. Access cost of ivermectin in Israel. Okay, I'm sure I would remember it. Kurt Dish says, are there any difference in efficacy if I take ivermectin with high dose but short term versus I take ivermectin in normal dose but in long term? Can you elaborate the difference? Yes. Yes. So let's quickly look at this. I'm going to explain this the way I explain it to my friends and family who um, want to talk about high dose and why high dose. So imagine we have these cells, 3, 4 cells, and they all have a number of ACE2 enzymes on them. Let's say they all have 10 enzymes on them, 10 each. And we give ivermectin. We know that these enzymes, some of them will be used by the virus. Virus would not take all of them. It would use some of them. Let's say the virus would use 3 from each. And now we want to stand ivermectin at guard. And so what we want to say is we don't want all the ACE2s to be covered by ivermectin, because then the ACE2's function would be disrupted. So let's say we send ivermectin in and say, hey, you know what, go and block 4 of them. So now the ivermectin would have less chance, because there are some that are already, I'm saying ivermectin, the virus, there is less chance for it to connect. So again, we know that it does not, ivermectin would not just go and block the ACE2s. Ivermectin would actually get into the cell and it would block RDRPs or block other enzymes. Point, I'm just giving an example with the for the concentration. Now imagine if we have a virus that can very quickly go from one cell to the next one and then bind with higher affinity and then go to the next one. That means we need to stand guard at more places. That means we need a higher density or concentration of the drug. That is why it is important to give a higher concentration if somebody has greater viral load or the area of outbreak, for example, in India. So that is why the concentration difference is needed. If the virus is growing slowly, then you can give smaller doses for longer period of time. But if the virus has become more efficient, then you have to give larger dose. So Svetlana says, is it plausible to try ivermectin for a person who has GVHD after bone marrow transplant? Thank you for, have to be given. So ivermectin, the efficacy may not be as great, but yes, should be tried. Again, not a prescription or medical advice, just in theory or from an educational point of view. Yasmin Martinez says, Dr. Bean, I finally got my dose of ivermectin and totally forgot to ask if I can take Lexapro while I'm on ivermectin. So let's do this. I always do this. This is just to protect my own self. So if I go to drugs.com and do the interaction, so ivermectin and let's say so I'm so sorry, I'm using an ad blocker. So interaction between these 2 drugs, no interaction. But then there are other concerns with the drug itself, which I'm sure that the person who's taking it knows it. But at least from drugs.com, no interaction. So Redpoor, I would look into this one, function of extracellular vesicle-associated messenger RNA. So what we're talking about is that there is messenger RNA that is sitting in vesicles and is outside and probably going to be taken up by other cells in metastasis. So if that is the case, the question is going to become cancer cells, they just do what they want to. So I'll look into it, but I don't think it's going to be an interesting mechanism for normal people, meaning non-cancerous side. Arun says monocytes are the biggest cells in blood. Does it allow more spikes to accommodate? How ivermectin handles the spike debris, green fungus also there in India? So more spike or less spike is not related to the cell's size itself. It is really related to how many spikes are produced and where they are sitting, and how fast the cell can kill them. Normally, these cells, phagocytic cells or monocytic cells, phagocytic cells, monocytes are phagocytic as well. What they do is they pick up debris and they burn it in their with their oxygen. So various cells have various mechanisms. For example, neutrophils have cytoskeletal changes and the enzymatic changes. That is how they burn or fight. Macrophages have more of a gene reprogramming, monocyte and macrophages, gene opening and reprogramming, which became a huge hoopla that, oh, there is gene reprogramming. That is what happens in the innate system, that the genes open up and they work. So macrophages and monocytes, they work more with the gene expressions and then protein production as a result of that. So when we have a monocyte or when we have a macrophage, their function at some point is going to be to clear the things in them. And if they're not able to clear the things in them, it is the T helper 1 cell system or adaptive system that will activate them with interferon gamma to ask them to clear themselves. And if they cannot clear themselves, then there is a function called pyroptosis, which would mean that the phagocyte would break. But before breaking, what it would do is it would create a lot of inflammatory cytokines in it, so that when it breaks, it provides help even when dying. And that is when it breaks open, all those cytokines would come out and activate the immune system. This is called, it is different from apoptosis. This is called pyroptosis. And so what happens is, to your question, the idea is that the cells should be able to clear themselves out. Sometimes they're not able to clear themselves out. And that is when they get frustrated and then they keep making cytokines. Although frustrated phagocytosis is a different term. Now back here to you, how ivermectin handles the spike. So ivermectin, one of the studies, actually 2 studies in silico, I was actually sharing them with Dr. Paul Merrick a few days ago. There are 2 in silico studies that show that ivermectin can bind with this spike protein. That is one. Secondly, we also know that ivermectin modulates nuclear factor kappa B pathway that is triggered by this spike protein's presence. So both of those mechanisms would help reduce the cell's ability to make cytokines. So ivermectin would not remove the debris, but it would calm down the cell with the debris. And then if we also give steroid, then the whole system will be calmed down. These cells that have the debris, they would start cycling, they would start dying and going away, and most of them would convert from M1 to M2. Some of them would do pyroptosis and die. And so that these are the kind of clearing out functions. All inflammations in healthy people would come to an end by these mechanisms. So these are not out of this world mechanisms. They're part of the immune system's function. It's just that we have to give a chance to the immune system when spike proteins are bothering it. Bilal says, Dr. Mubin, so if those based mechanisms, Doug would say Mubin should change the screen more often. Dr. Mubin, so if those based mechanisms occur, which based mechanism? With the spike from the vaccine, does it mean it's going to be there permanently with damaging the body? No, so I don't think so. Eventually, immune system is going to do pyroptosis, I just talked about, or it is going to take care of it. It's just slow progress. The reason it is slow is monocytes have lesser lifespan. So they can be cleared out fast within days. Phagocytes sometimes can live on for years. So that is where if a macrophage is just frustrated and is living on for a long time, it's going to keep causing inflammatory activation. So we have to calm it down by giving steroids, or we have to calm it down by giving ivermectin, so that thing that is bothering it is calmed down, and then it can convert to M2, or it can die away, or it can cause pyroptosis and go away. So we have to wait for it to clear out. The clearing can be accelerated by these drugs. Iacomius 23, thank you very much for the super chat. Daniel says, Dr. Bean, any recommendation to protect oneself from long haul effects of vaccine and of COVID for people with lots of family history of Alzheimer and Parkinson's? Very simple. Continue to take ivermectin. Again, not an advice, just generally, this is what I ask my patients. Just keep taking ivermectin. Ivermectin not only helps with reducing the chances of long haul with the active infection, but the same with the vaccine too. Doug says, a hypothetical person's vitamin K2 is MK4, 100 microgram capsules. Should he take 10 to get 1,000? It claims that 100 is 83%, and his vitamin. So from a math point of view, I think you're correct. It just scares me to take 10 capsules. Patricia Norikis says, I'm on 4th week ivermectin. Do I do just July 1st? Ivermectin, July 1st, 3rd, and 7th. So July 1st, 3rd, and 7th, and then every week, and do the same for each month. So I usually make it very simple. I don't do day 1, day 3, and then weekly. I just say weekly. If I feel that somebody needs some, for example, they got exposed or they're showing some symptoms, I give them 5 days continuous and then weekly. So Redpour says, these papers blatantly state that exosomes aren't exclusively related to cancer. To angle that it is purely a cancer-related issue isn't accurate. Okay. Also, mRNA injections were developed as cancer research. I know that. But mRNA injections were not for the exosome activity or intercellular communication activity. They were, again, used the way we... So if you somehow said that messenger RNA itself is going to sit outside the cell, then the whole vaccines concept and those theories are gone. Because if you go, I was reading the patent today from Moderna. So they are not saying what you are saying here. So if you're saying this is something additional that they forgot, then maybe you know more than them. Frisco says 100 fully vaccinated versus 100 unvaccinated on the perfect ivermectin for the last 30 days. All 200 get exposed to a large viral load. How many from each group do you expect to end up in hospital? So Egyptian study said 74% efficacy by ivermectin. There are other studies that say 84% as well by ivermectin prophylaxis. Vaccine efficacy, we know some vaccines are 60-70%, some are 94-95%. They could be different with various cohorts as well. They are different with various variants as well. So I think this generic question, I can just cite these efficacies, but you'll have to look at the cohort and then see what kind of prophylaxis they're doing. I think that it would probably be the same on both sides. So Redpour says, I find Dr. Bean to be a man of too much integrity to disingenuously disregard exosome topic as an unrelated cancer issue. So don't regard it with the vaccine, but tell me, what are we talking about? If you are, once again, if you're saying that somehow vaccines RNA is a communication mechanism between the cells, then what is it doing? What is the communication it is trying to do? Guitar Man says, are you concerned that the current antibodies in the vaccine might bind and not neutralize with future variants, antigen sin? No. So, and we have done this discussion before as well. I actually have a discussion done for ADEs and the antigen sin before. So Jody says, in summer, do you need vitamin D on shady days, or does the body store enough? Body does store enough as well, but it also depends if you are getting enough exposure, sun exposure too or not. So Maxima says, how much do you think vaccine will reduce COVID long hauler? Is there any data on long hauler after vaccine? Similar to infection symptom. So we know that after vaccine, some people are experiencing it. I have no idea, or I haven't read a study that shows what percentage is getting that. Number one. Number two, how do you think vaccine will reduce COVID long hauler? So this is the data coming from data or observation. I don't think it is a study. From Bruce Patterson and Dr. Yo. They say that when they are managing, and I think by far they have a very large number of long haulers that they're managing, successfully or not, that's I do not know. But they say that 20% of the cases vaccine helps. What I have been talking with some, so not 5,000 people, with some, they say that one dose helped. In some cases, second dose actually, they said, became bad. So they had the infection, they became long COVID, they took one vaccine dose and they felt better. Second made them feel bad. So this is all over the place. I have no idea how to connect these dots because I don't have enough data. Muhammad Marjan says, is there any recorded case of COVID-19 disease after vaccination? Question, is PCR B positive after vaccination? Yes, many. Not only recorded cases of disease, but even deaths. We were talking about that for UK yesterday. So yes. So Jerry Brown says, what are your thoughts on the comments recently from Robert Malone about the bioethics and transparency of adverse effects? And what do you think about Canada's vaccine lotteries? So I would answer the first one. I really think that the adverse effects system, as much as it is out there, a proper understanding of that and then a review of that by the health authorities. For example, just like I am that crazy guy who thinks that on every street there should be stalls and we should be educating people and giving them vitamin Ds and packs of ivermectins and hydroxys and telling them, hey, if you are anti-vax and this is how you can protect yourself, and other, if you are a pro-vax, this is how you can do it. If you're a woman and you're going to take vaccine, this is how you can be protected, and don't take this vaccine and take this vaccine. So maybe I didn't think that this was too utopian or too idealistic, because at this time in the world, what else do we have to do than to finish this pandemic and protect ourselves? But that didn't happen. Similarly, this idea that verse is there, there is a message I got this morning by a woman who has post-vaccine side effects by Pfizer, I believe. And she said, I reached out to Pfizer and I said, I have these side effects. And they were not interested in listening. And they said, go to your local pharmacy. Local pharmacy for what? Go get medicine for your side effects? That's what they meant. And she had pretty bad side effects. And here is the deal. When a youngster who's healthy and athletic and running around and doing exercises and keeping themselves fit, when they fall with this thing, it is unfair to then say, pace yourself, as Dr. Yo said today, or it would go away, or this is just in your head. This is, all of a sudden, people have not just gone crazy to start making up these things. So yes, there is a problem. I had thought that there will be weekly reports where healthcare authorities would come out and say, this week we had following number of cases. Here are the ones that we think are related. Here are the ones that we think are not related. Here is what we are researching. And then they would say, here are the ones that we were researching and we found following things, and educate people and update them and allow them to think. And that didn't happen either. So as much as bioethics and transparency, I think that transparency, you can go to VERSE and see that. It is the digestion of that data, making sense of it, and then coming back and saying, here is what it means. That is what is not happening. And if that is what Malone is saying, then he's right. Now, I do not know about Canada's vaccine lotteries, so I can't comment on that. Ashwini says, Ashwini Das Gupta. Dr. Bean, thank you for your service. Question, why has the DGHS in India refuted and banned the use of ivermectin, even though it has shown promising sign in Uttar Pradesh? I think it is more political, more ego. Someone saying, well, there are people in FLCCC feeling great about it, and this, we should just get ahead of it. I don't know. I think these, ivermectin is safe enough that it should have been allowed, even if these big wigs thought it is a placebo. Even if it was thought to be a hope, and that hope was making people happy, then they should have let that happen. So M. St. Clair says, excellent job tonight on FSCCC. Great discussion. Thank you very much. So Redpur says, copy paste them. The question again is, what am I looking at? Is there a point of this discussion? If you just want me to go do some research, why? What is the takeaway for you and me? Maximus says, what about theoretical possibility of developing new COVID long hauler from breakthrough COVID cases? Because I heard many long haulers not very symptomatic with the infection even after vaxxed. There are long haulers with the infection as well. I don't know. Again, there is something that happens even after vaccination, which allows either the spike protein to end up in a cell, or a hit and run to happen on the immune system, or macrophages becoming upset for some other reason, or MCAS system becoming unmasked. There is something, because there are symptoms. So exactly what is the mechanism? We can only think in those terms that we know so far. It would continue to evolve. The good news is that management approach is consistent so far. Building Maker says, I watched FLCCC update tonight. Is MCAS related to eosinophils or only on mast cells? So you know that MCAS and the cytokines developed that causes mast cell activation. Those cytokines can actually cause eosinophilia as well. But MCAS itself is a separate thing. Okay, so maybe Redpool was responding to Kelly's question, not mine. Okay, so Art Ninjiox says, see, I'm seeing you after a long time. Which of the B vitamins should be recommended to a patient if the patient is concerned about long hauler symptoms of SARS-CoV-2? Why just B? So we talked about vitamin D and C. Here is how I generally do with my patients. I ask them, and myself, I ask them to take daily RDA as routine. And then on top of that, take some antioxidants, take vitamin D, vitamin C in addition. This is how I do it. Vitamin Bs and folic acids need primarily when we have the cell division going on and we need help with that, although they should generally be there. That general coverage will be by the RDA. then extra coverage may be needed when actual infections or actual cell divisions are occurring. No worries. No need to be sorry. I just did not understand it. And then I looked at your question and I understood that was a separate discussion going on. So Surfret says, could this long M1 state in post-vax people be actually beneficial in creating stronger immune response, meaning better protection against the virus? If the macrophages are going nuts without adaptive arm doing much because the vaccine is gone, or the spikes are sitting in the cell and they are not doing much for the adaptive arm, then it is useless. But if the vaccine is being presented and the cells are participating and the inflammation is occurring and that is causing both systems to be active, then it is fine. The question is, long hauler is not a vaccine continuous training for so long. It is, our body can start producing vaccine or infection related antibodies within 5 days to 10 days. Afterwards, if the immune system stays bad for many months, then it is dysregulated. Cool. So medical science says any use of coenzyme Q10 to boost your immunity. I talked about it, coenzyme Q and the immunity. It is very important for reactive oxygen species, but it doesn't boost the immunity. Building Maker says, lol, Dr. Bean, I'm an architect, not a doctor, so I don't usually know. Okay, fair enough. Sorry about that. Art Ninja says, thank you, Humble Bean. Welcome. Kurt, I would have no idea. So thanks for your work. Welcome. What are your thoughts about Linhua Qingwen used in China for COVID SARS? Heard it's effective. I have no idea. I didn't even hear it. So I'll have to look it up. So GG says, is the right way to think about it. Isn't COVID basically a worst version of the vaccine? Anything negative the vaccine can do, COVID can do anything perhaps worse? Yes, that is one. Plus, vaccine has its own unique problems too, and that is it has adjuvants. Generally, vaccine is supposed to do a minor, as you said, a minor effect of what the big monster would do. There you're correct. But the vaccine has this extra adjuvant related issue as well, which in some people may be prominent. So Maximus says, I mean, COVID virus long hauler, not well. Same answer. COVID virus long hauler means either there is a virus hit and run. That means virus is not there, but immune system is going nuts. And that could be like macrophage activation syndromes, or virus debris sitting in the cells, like monocyte, as we know from Patterson, or the uncovering of the MCAS system, or the GIT or other places where the virus had been sitting and is shedding. So there are multiple mechanisms. It depends what is going on. Cool. So let's do this. So there's another question from Colin. I was going to say, let's do this. That will stop. Colin says, what about cod liver oil? Does it help with the vitamins? Yes. So if you see MCAS, not MCAS, mast cell activation, we got to give fish oil as well. That is helpful. Rajesh says, did you research Giloy herb? Not yet. Today was so busy that I had to prepare for FLCCC, which was starting at 4 my time. So I had to prepare a couple of hours before. Then I had the morning discussions. I had to prepare for these lectures too. So I didn't even have time to look around. Cool. So let's do this. So there's a question, actually multiple. Doug says, why do we trust anything the main institutions tell us? They fail to conduct basic sciences and medical practice in regards to ivermectin and other proven treatments. Something doesn't add up. You are correct. So here is how I see it. If you go to CDC and if you look at the question about how to manage pregnant women or children or people with cancers with COVID, for majority of the time, they'll simply say, we do not know, the data is evolving, we are learning more, we are doing this, we are doing that. How do they become so deterministic when it comes to ivermectin, where we actually know more? And if they are that naive, because it's an evolving situation and after 15 months they still do not know much, then get away from ivermectin's way as well, because your credibility there is also not useful. And if they say we are very credible and very super scientific on ivermectin, then why don't you use that same thinking hats and be more deterministic in other simple things? They cannot even get their head right on seed, on mask and aerosols. So I'll become more upset when I talk about it. Jean says, regarding vitamin D, is it best to take it or avoid it during the vaccination period? So take it. I think that vitamin D, RDA, vitamin C slightly above RDA, and ivermectin should be continued through the vaccine time. Maximus says, sorry if my question was not clear. I'm sorry. I'm going to look at it again, Maximus. So will vaccine reduce that chance of becoming a COVID virus long hauler from a breakthrough infection? Yes, ideally, yes. Vaccines can cause their own symptoms, but yes. So this is the common one I like. Comus23 says, are there any double-blind, placebo-controlled gold standard trials for ivermectin and COVID? I have no idea what you need from their gold standard. I'll ask you a simple question. FDA just very recently approved a couple of drugs. Check out their gold standard. They were actually approved with phase 2 trial on a small number of people. So the idea of running around with the gold standard tests, it only gets invoked when somebody wants to talk negative about ivermectin. But FDA, go check it out. Check out how bamlanivimab was approved. Bamlanivimab was run on 400 people. Out of those, 300 people were given different doses to 100 each, and 100 were given placebo. So essentially, the dose understanding is phase 2. So they used that to say 400 people, but essentially there were 200 people, any 200. And then based on that phase 2 trial, like a trial, they called it phase 2 and 3, and they said approved. Did they have a gold standard large study? I'm sorry I get annoyed with this question. For me, let me tell you how I work. Wherever there are studies, awesome, they're useful to understand. If there are no studies, and thanks to Kelly from Australia, then Dr. Alam from Bangladesh, there were people who tried something different. I would not have even thought about using ivermectin for COVID. They did it. They found it. They used it. They came back and they said, hey, this is great. And then we followed in their footsteps and we saw this works as well. And when we saw this works, for me, if you came to me and said, Mubin, stop giving ivermectin to patients because there is no large study. And when I ask the question, what do I give them? The answer will be nothing. Let them be at home. If they become too sick, let them go to hospital. Over there, we'll give them remdesivir that is proven to be of no use and actually harmful. Plus, we'll give them steroids which is fine. That steroid is a useful thing. And we'll do some other song and dance. But at that time, patient would be in a really bad state. So if I ask you that, okay, fine, ivermectin is pretty safe. It's not going to kill the patient. And you are going to give them nothing. So fine, let me give them ivermectin. Maybe I'll just give them hope. If they're going to end up in hospital, they're going to end up in hospital either way. How does that look bad? And this is a incorrect position to say by giving ivermectin you would harm someone. How would you harm someone? There is no other approach that is offered by these big companies, the organizations. If they said, for the early treatment, we consider following drugs to be given, and they are the ones that are efficacious, and now you are giving something that is contrary to them and maybe as good as placebo, do this, then I'll say, fine, yes, maybe I'm wrong. But man, their answer is, let the person be at home, quarantine them, let them wait to end up in a hospital, and if they're lucky enough, they would not. Well, when I give them hope, I also observe that they don't end up in a hospital and they don't become long haulers. So do you think I would stop? DTS says, did Dr. Bean just do a gang? Is this a gang symbol? I was just saying out of 400, 100 and 100, placebo and 100. So was it a gang symbol? That would be cute. All right, so let's stop for today. I have been sitting in this chair for now many, many hours. Please do me a favor. Please like, subscribe, and share. And if you would like to support this work, there are 3 links in the description. One is if you would like to buy me a coffee. Other one is if you would like to use PayPal to support this. And the third one is if you would like to be a patron. Thank you very much, and I would see you tomorrow. Tomorrow, 11 a.m. in the morning, Pacific time. Bye-bye.